In last video, we have discussed syntax trial and its results at short-term follow-up. In this video, we will discuss syntax trial results at long-term follow-up. Let's first quickly go through the results of syntax trial at 12 months. The primary endpoint of MACE was significantly lower in CABG group compared to PCI group, mainly because of excess repeat revascularization rates in PCI arm. Thus, this trial failed to establish non-inferiority of PCI compared to CABG. Incidence of stroke was significantly higher in CABG group. The incidence of other individual components of MACE, that is, death from any cause, and myocardial infarction were similar between two treatment arms. Then the incidence of symptomatic angiographically confirmed graft occlusion in the CABG arm and stent thrombosis in the PCI arm were similar between two treatment groups. The deaths from cardiac cause were more common in PCI group, while deaths from non-cardiac cause were more common in CABG group. Now let's see subgroup analysis at 12 months. First, let's go through the subset of left main disease with or without vessel involvement. In this subset, CABG was found to be better than PCI. If we further subdivide this subset, in those patients with isolated left main or single vessel disease involvement, PCI was found to be slightly better than CABG, while in those with double vessel or triple vessel disease, CABG was found to be superior. In triple vessel disease subset of patients without left main involvement, CABG was found to be better than PCI. In diabetic patients, CABG was significantly better than PCI, while in non-diabetic patients, though statistically not significant, CABG was found to be better than PCI. Now, let's see the results of syntax trial at 3 years. The incidence of primary endpoint was significantly lower in CABG group, mainly because of excess repeat revascularization and excess of myocardial infarction events in PCI arm. Though numerically higher, the incidence of stroke was not statistically significant in CABG group. There were two important differences which were observed between results at 12 months and 3 years. First, the incidence of myocardial infarction, which was similar between two treatment arms at 12 months, but at 3 years, the incidence of myocardial infarction was significantly lower in CABG group. The second important difference was the incidence of stroke, which was significantly higher in CABG arm at 12 months, but at 3 years, the incidence of stroke, though numerically higher, it was not statistically significant in CABG group. Now let's move to the subgroup analysis. In left main subset, the incidence of primary endpoint was similar between two treatment arms, while in case of triple vessel disease subset, the incidence of primary endpoint was significantly lower with CABG arm. Then when stratified by syntax score, all patients with low and some patients with intermediate syntax score did equally well with both CABG and PCI. Now let's see the results at 5 years. The results at 5 years were similar to those observed at 3 years. The incidence of primary endpoint was significantly higher in PCI arm because of excess repeat revascularization and myocardial infarction events in PCI arm. The incidence of stroke in CABG group, though numerically higher, it was not statistically significant between two treatment arms. The incidence of stent thrombosis and graft occlusion did not differ significantly between two treatment arms. Now let's see the incidence of all-cause mortality at 5 years. Though the incidence of all-cause mortality did not differ significantly between two treatment arms, the incidence of cardiovascular, cardiac, and MI-related mortality was significantly lower in CABG arm. Now let's move to subgroup analysis at 5 years. In left main subset patients, the excess of repeat revascularization observed in PCI arm was counterbalanced by excess of stroke observed in CABG group. Thus, primary endpoint did not differ significantly between two treatment arms. Now moving to subgroup analysis in TVD subset of patients. The primary endpoint was significantly higher in PCI arm because of excess repeat revascularization, myocardial infarction events, and all-cause mortality in PCI arm. The incidence of stroke did not differ significantly between two treatment arms. In contrast to the findings observed in left main subset of patients, in those patients the incidence of stroke was significantly higher in CABG arm, while in TVD subset of patients, the incidence of stroke did not differ significantly between two treatment groups. So at 5 years, the MACE rates were higher in PCI group compared to CABG, with higher risk of repeat revascularization, myocardial infarction, and all-cause mortality in PCI group, with similar risk of stroke between two treatment groups. When stratified by syntax score, all patients with low and left main disease subset of patients with intermediate score did equally well with both the treatment strategies. Now moving to all-cause mortality at 10 years. The incidence of all-cause mortality did not differ significantly between two treatment arms. Then moving to the subgroup analysis. In patients with left main disease with or without vessel involvement, the mortality rate was 26% in PCI arm, while 28% in CABG arm. Then, in patients with triple vessel disease without left main involvement, the mortality rate in PCI arm was 28%, while 21% in CABG arm. In diabetic patients, no treatment interaction was observed between two treatment groups in terms of all-cause mortality. Now, moving to revascularization results, the incidence of repeat revascularization and multiple repeat revascularizations were higher with initial PCI compared to CABG. At 5 years, the composite safety endpoint of death, stroke, and myocardial infarction after initial PCI was significantly higher in patients who underwent repeat revascularization compared to those who did not undergo repeat revascularization. This same trend was observed after initial CABG as well. So moving to the cost effectiveness, the total procedural cost was higher in PCI arm mainly because of large number of stents required in the PCI group, while overall hospitalization cost was higher in the CABG arm. CABG was found to be more cost effective over 5 years of follow-up. Then from subgroup analysis point of view, PCI was found to be more cost effective in patients with left main disease and those with low syntax score, while CABG was found to be more cost effective in patients with triple vessel disease and intermediate to high syntax score. Now let's move to the quality of life assessment. The Seattle Angina Questionnaire was used to assess the quality of life. Compared with baseline, both treatment groups showed significant improvement in cardiac-specific health status as assessed by 1-month follow-up, and then further improvement has observed at 6 months and 1 year, which were largely sustained at 3 and 5 years. Then compared to CABG, patients who underwent drug-eluting stent PCI had more rapid health status improvement at 1 month, but these differences were not sustained at 1 year. Now, with reference to angina-free status, the patients who underwent CABG were more angina-free at 1 and 5 years follow-up compared to PCI group. Especially the patients with high syntax score were more frequently angina-free at 5 years with CABG than PCI, while the patients with low to intermediate syntax score, no difference was observed in the angina-free status. So these are the articles you can go through for further details.